Hi guys, so my name's Sharone and I'm a PA in orthopedic surgery. The intent of this video is to provide new PAs switching into orthopedic surgery, or students, both PA and medical students, a little bit more information about the most common conditions that I see in orthopedic surgery clinic. So I hope you guys enjoy and learn something new. So like I talked about, this is going to be a three-part series actually, talking about the most common conditions that I see in clinic. And in this video, the first video, we're going to talk about knee arthritis. So just as a disclaimer, this video is for educational purposes only. So if you're suffering from an injury, this is not supposed to supplement any medical care that you should get regarding that injury. This video is for educational purposes only. Enjoy! All right, so I put together a common way that patients with arthritis will present to clinic. So 76-year-old female presents to clinic with gradual onset right knee pain for the past 3 months. She denies any known injury, anything that could have caused the pain. The pain is localized diffusely over her knee. It does not radiate up or down the leg, and it's worse after long walks and prolonged standing. She endorses catching and swelling in her knee, and she hasn't tried any prior treatments for her knee pain. So this is pretty much how a lot of patients with new arthritis present to clinic. So you've got a lot to talk about here. So next, you go to the physical exam and you want to gather more information. So typically I'll ask my patient to go ahead and hop up on that exam bed. So it might sound like a nice way to introduce a physical exam, but also I'm very objectively watching to see how the patient ambulates over to the table. So do they grab a cane? Do they grab a walker? Do they look like they're in a lot of pain? Because it's very important to gather both subjective and objective evidence as to the level of pain that the patient appears to be in. You also inspect, so you look to see, do you see a visible effusion? Also, do you see a varus or valgus deformity? So what this means, as you can see on the left-hand side, there's a picture of a valgus deformity, or as some people call it, is knock knee. So it's a deformity where the knees turn inwards. And it's a lot of different things can cause varus or valgus deformities, but most commonly we'll see it with lateral compartment arthritis. So there's three different compartments in the knee. There's the medial compartment on the inside, the lateral compartment on the outside, and the patellofemoral compartment underneath the kneecap. And I can talk to you guys a little bit more about this on the imaging slide. But in valgus deformities, you'll have severe arthritis of the lateral compartment causing bowing inwards of the knees, like you can see in the left picture. Varus deformity is the opposite. So you'll have severe medial compartment arthritis, where the cartilage, meniscus, bones are worn down so that they're very narrow joint space on the medial side, contributing to a bow-legged deformity. So these are some things that you can look to see and can cue you into the severity of arthritis without even having to look at the x-rays. So you'll also palpate. So I'm very thorough about making sure that I palpate the joint line. So on physical exam, you can take the knee and feel for the divot right between the femur, the femoral condyle, and the tibial plateau. And you'll kind of extend and flex the knee gently so that you can feel where that joint space is, that joint line, and palpate right there and see if you can elicit pain. It's also important to palpate right above and right below so that you really ask the patient, is the pain coming from the joint space or is it coming from the surrounding ligaments or musculature? So palpate the joint line. Also important to palpate the joint line of the patella. So the medial and lateral patella facets. Important to do that as well. Next, you'll get the range of motion of the knee. So you want to fully extend the knee out, see how straight you can get the knee, and see if patients have pain or if they have a flexion contracture when you do that. Can they fully extend the knee, or is it kind of stiff and causing a lot of pain? And then when you flex it back, note to see what range of motion they get. Do they get to 90? Do they get past 90? How far do they go? And where are they having pain? So range of motion is really important in arthritic patients. You also want to do some special tests. So all your special tests on all your new patients But importantly, you can do varus and valgus stress. So stress the inside and the outside of the knee and feel how much the joint space will open up. So if you have a patient with severe arthritis, sometimes you can have significant laxity with varus or valgus stress. Um, but you want to make sure you still have a firm endpoint. That can kind of cue you into whether the surgery is going to be pretty difficult or not, but it's also important to see how much laxity they have on that. Patients can have a positive McMurray because in the joint space, you've got bone, cartilage, and your meniscus. So when you do a McMurray exam, one thing that can wear down other than the cartilage is your meniscus. So you might also have a positive meniscus, and commonly you will. If you want to check for patellofemoral arthritis, you want to do a patella grind test where you push down on the kneecap while you flex and extend the knee and see if that elicits pain. You can also feel for crepitus in the patellofemoral compartment by putting your hand over the kneecap and extending and flexing the knee and see if you feel the popping and grinding sensation of the bone rubbing. So that's the crepitus that you feel. Those are all the most common physical exam maneuvers that I'll do on arthritic patients. So next, you're going to want to make sure you get the right imaging and examine the imaging and go over the imaging with a patient. Patients with arthritis, especially if it's your first encounter, can be, somewhat heart-wrenching for someone to learn that they have this new condition that is not really just going to go away. So the x-rays that I get on patients is an AP lateral Rosenberg, or some people call it a tunnel view, and a sunrise view. So if you look to see the pictures on the left-hand side, the far most left picture is the lateral view. The picture to the right above the below picture is the AP view, so anterior posterior, and below that is the sunrise view. The sunrise view is important to look for patellofemoral arthritis. All of these views have to be weight bearing. You have to have weight bearing views to see the integrity of the joint space. The Rosenberg view is a special view that is important to get in patients that have that you're suspicious for arthritis because it'll show early onset arthritis. It is a posterior anterior, or PA view, of a patient with their knees bent at 45 degrees. And it's a good view at looking posteriorly of the knee and seeing signs of some early arthritis. So after you get these views, these x-rays views, all four are really important. After you get these x-rays views, commonly what you'll see is joint space narrowing. So when you look at the x-ray, you'll see the bone, the white, and between that is the joint space, or the black. What lies in that joint space is the cartilage and the meniscus. That does not show up on an x-ray. So the narrower that black area is, the more the cartilage in the meniscus has worn down. So that is evidence of arthritis. You'll also see sclerosis, which is heightened white line right on the edges of the bone. Sclerosis is evidence of calcium deposition and inflammation around the bone. So that's another sign of evidence of arthritis. You can also see subchondral cysts, or some areas underneath the bone that have some fluid in them. You can also see, sometimes you can see an effusion. So in the lateral view, you can see a white fuzzy appearance above the patella. So that's evidence of effusion. And in the posterior part of the knee, you can see a Baker's cyst. Sometimes that almost looks like a calcific deposit because it's so white and so well delineated. But that's actually a Baker's cyst, and you can also see that on a lateral view. So if you're highly suspicious of degeneration or arthritis and you don't really see too much on the x-ray, or you see some signs and you don't feel completely confident correlating the pain to arthritis, you should get an MRI, because sometimes you can be really surprised by what the MRI shows. So the MRI, sometimes you can see meniscus tears, cartilage degeneration, insufficiency fractures. You can definitely see that, but that is part of the arthritic picture most commonly. You can also see bony edema and subchondral cysts and synovitis. So, commonly in patients with arthritis, they'll also have a meniscus tear. And this opens up a whole area of discussion with the patient. Usually the patients say, should I get surgery for my meniscus tear? What I say to that is when you have arthritis, you develop degeneration of the cartilage, and after the cartilage degenerates, your meniscus is pinched in between there as well, and that will also degenerate. So just because we fix the meniscus and you have some tears of your meniscus, that doesn't mean necessarily that your pain's going to go away because you have overall arthritis. So that's a really important thing for a lot of patients with arthritis to understand, because a lot of patients are going to want to look for any way that they can basically get pain relief. And they have to understand that a meniscus tear does not necessarily mean that that is what's causing the pain in this picture. It's overall, depending on the scenario, is probably more so because of the arthritis. All right, so you've done all the hard work and you finally diagnosed your patient with arthritis. So now it's time to talk about the treatment with your patient. So the treatment breaks down into conservative or non-surgical and surgical treatment options. Typically, we'll start with the conservative treatment options, especially if you haven't really tried anything yet. So conservative options include exercise and weight loss, braces, Tylenol, anti-inflammatories, and other medications, physical therapy, and injections. So it's very important that you really talk about weight loss in your overweight and obese patients. It's very common to see obese patients with arthritis. And I spend a lot of time with these patients talking about weight loss, especially in how weight loss can slow the progression of the disease because it reduces the pressure on the joint space. So it's really important that patients work on that that fall within that category. Tylenol is technically first line in treating arthritis, and then anti-inflammatories. So there's a lot of different types of anti-inflammatories, and before I choose one for my patient, I'll do a history to figure out what risk factors they have. So I'll ask them, do they have any cardiac, kidney, or GI conditions that I should know about? As you guys know, you have your non-selective and your COX-2 selective NSAID or anti-inflammatories. So the history plays an important role in what kind you select. So for patients that don't have any risk factors, you can do a non-selective or one that works on the COX-1 and COX-2 pathway. So that's going to be, for example, Voltaren. It's a really great anti-inflammatory that typically, patients can have some good relief with. So I like Voltaren. So naproxen is a great NSAID for patients that have history of cardiac disease, particularly hypertension or past medical history of any cardiac complication. In cardiac patients, sometimes you want to think about not even prescribing NSAIDs, especially if they have a condition that predisposes them to fluid retention, such as congestive heart failure. In that case, Tylenol might be the better option. You're going to want to go ahead and do your COX-2 selectives in patients that have GERD or history of GI bleed. So Celebrex is what I like to prescribe in those patients because they have less gastric irritation. Capsaicin is another medication that you can try. It's a topical application that's derived from chili peppers. So you want to make sure that your patients aren't touching their face, particularly their eyes, their nose, or their mouth, because it can cause a lot of chili pepper-like unpleasantness if they do. Tramadol is a weak opioid. I don't usually prescribe opioids for arthritic pain, but if I have to, I'll prescribe it in bridging a patient before surgery. So it's a transient relief that I'll provide them with. Tramadol, you have to know the side effects of when you're prescribing, particularly that it increases the serotonin in your body, so you're wary or cautious about serotonin syndrome. Patients, particularly that have a history of depression and take antidepressants, those medications can also increase serotonin, so you want to be cautious when you're prescribing tramadol with antidepressants, and typically I'll avoid tramadol if they do take antidepressants, particularly MAOI inhibitors, which I don't think is really commonly prescribed anymore, and tricyclic antidepressants, because the tricyclics have a narrow therapeutic index. So you have to be really cautious with that. Antipsychotics, such as lithium, also can increase serotonin. So take a quick look at the medications and make sure they aren't on antipsychotics as well. So those are the medications that we think about. You can also provide injections for patients with arthritis. Usually we'll start with cortisone. There's more data suggesting that that can provide more relief. And then we'll switch to hyaluronic acid if patients don't really have a lot of relief with the cortisone. Some patients will also ask about PRP injections, which we'll talk about in the next slide. If patients aren't really interested in medications and are asking about allopathic treatments, you can try turmeric. It's a natural anti-inflammatory. I tell patients that there aren't a lot of studies showing the effects of turmeric or any diet in particular helping with arthritic pain, but it is an option for patients to try if they are more interested in the allopathic or non-prescription medication pathway. So braces are another option. What we prescribe are medial or lateral and loader braces, and what those are is exactly what they sound like. They actually take the pressure off the medial or lateral compartment. So those are another option for patients with arthritis. You can also try patellofemoral brace, which has a hole for the kneecap, and that'll help the kneecap stay in a optimal position when you're flexing and extending the knee. So based on where the patient localizes the pain, you can prescribe one of those braces. It's best if they have pain in one compartment, so that if you do a medial and loader brace and you take the pressure off the medial compartment and it puts it on the lateral compartment, they don't also have pain on both sides, so it kind of increases their pain somewhere else. So it's usually best for pain that's localized to one area. And then if patients fail conservative treatment, they have a lot of pain, it's interfering with their everyday life, then we'll talk about surgery. So arthroscopy is definitely something you can talk about if they have any meniscus etiology, and it is something that you can try depending on the patient case. Otherwise, you can talk about knee replacement. There's partial knee replacements and total knee replacements. Partial or unicompartmental knee replacements are indicated for unicompartmental knee arthritis. So when there's arthritis in either the medial or lateral compartment and no arthritis in the other one. So patellofemoral arthritis is not necessarily a contraindication for a unicompartmental knee replacement. However, if there's pain with patellofemoral arthritis, then it is a contraindication. So it's another option. Total knee replacements are generally what we provide for patients in clinic. So replacement of the whole knee. And I coach patients that the hardware can typically last from 10 to 20 years. We hope as long as possible, but that's what I will, let patients know. So we really try conservative treatment before jumping to surgical treatment. All right, so the common questions that I get from my patients regarding arthritis. The first question is, why do I have arthritis? So that's a great question, and there's a lot of different things that can contribute to the development of arthritis. Most commonly, it's chronic wear and tear and older age. There's other, if you have a history of inflammatory diseases such as rheumatoid arthritis, lupus, that can contribute to the progression of arthritis earlier. Prior trauma, or if you've had surgery in the past, if you've had a knee scope, sometimes you can develop earlier arthritis after a prior surgery to the same joint. So those are some things that we think about. There is something called a Charcot joint, which is really rare, but it's a good thing for providers to know about. So that can contribute to arthritis. It's a little bit of a different disease pathology where you have autonomic dysfunction leading to hyperemia and vascular congestion, causing osteoclast bone breakdown and basically a new kind of abnormal looking joint. So a Charcot joint is very rare. You can see it in patients with tertiary syphilis, but that's a rare kind of factoid just for providers to know about and be aware of because typically those patients will not have great outcomes with surgery. So most commonly, arthritis develops because of chronic wear and tear. Is there anything I can do to improve the arthritis? So usually what I feel like patients are getting out of this question is, can I reverse it? And the answer to that is no. We can't reverse arthritis. Conservative treatments can help. So I highly encourage strengthening the knee. Weight loss can decrease the progression of arthritis. But the only thing that can reverse the arthritis is going to be surgery and completely shaving off the arthritis and giving you a new knee joint. And then the last question is, what do you know about PRP injections and can they help? So PRP injections, or platelet-rich plasma injections, are kind of a new hot topic in orthopedics and orthopedic surgery. In terms of arthritis and providing these injections for knee arthritis, there isn't a lot of research and studies saying that they necessarily help. So it's a highly controversial topic. There are some research studies that say that they can provide relief, especially in early arthritis and the early stages of arthritis, but it's a highly debated topic and no clear evidence regarding one way or the other. All right, you guys are now experts on knee arthritis, so make sure you check out my other 2 videos on the other 2 most common conditions that I see in orthopedic surgery about meniscus tears and ACL tears. Thanks so much.